Our final speaker of the afternoon is Ms. Raj Khasriya, a dedicated consultant gynaecologist and urogynaecologist representing our event partners HCA Healthcare UK and practicing privately at the Portland Hospital. She is passionate about improving women's health across all stages of life. Ms. Raj Khasriya has been instrumental in advancing understanding and treatment of often overlooked conditions such as incontinence and prolapse. Her pioneering research in chronic urinary tract infections reflects her commitment to addressing the complex health needs of women. Let's give a final warm welcome to Ms. Khasriya as she brings her valuable expertise to our Women's Health event. Thank you.
Thank you very much. I'm not sure I deserve all of that. I know everyone must be tired. I'll try not to go on too much. So I wanted to talk about everything pelvic floor and my special interest, UTI, which every clinician will see, doesn't matter what you do. So very, very important. So this is me, as I've been introduced. Okay. And I'm going to talk about, briefly, incontinence, prolapse, a little bit about bowel health, because it's so intimately connected with the pelvic floor, UTIs. Yeah, and then you can ask me some questions if you like. Okay, so incontinence. So when a patient suffers with incontinence, of course, they're just sort of, I'm leaking. Okay, but for doctors, we separate it all out because the treatments are different. So stress incontinence is, as you know, when you leak, when you cough and sneeze and laugh and jump on a trampoline. I had a trampoline on that first slide. Someone said to me, Raj, why don't you print some cards, do a trampoline party for your daughters, and then, hand out your card. Get the mums on the trampoline. I didn't do that. So stress incontinence is very, very stressful, actually, and I think this is going to come back to education and how we view women's health as well, and how we don't tell people this is what is potentially going to happen to you. Risk factors for both types of incontinence. So urge incontinence is when you feel urgent, you cannot possibly hold, and often goes with frequency and needing to get up at night as well. And both of these things are happening later on in life. But both of them, one of the risk factors, of course, is just being pregnant, and then delivering babies. And of course, we're not telling women that these are risks because we're so scared, that they think that they are going to all say, well, I want a cesarean then, because that is slightly protective. Okay, but that's a bit of a, that's a bit of a us not really trusting the women that they know what they want to do. Okay, and I've put it's not normal, okay, because of course, I'll go on to, there should be a picture coming up here in a minute. This one. It's not normal, okay? But of course, tenor lady would have you believe it's completely normal. And of course, you can put those nice pants on and then, you just go, their tenor pants on and you go dancing and it's all good, okay? But it's not normal and things can be done, okay? So importantly. And I've put weight loss boo, okay? And, so I'm so glad I came after you, Stephanie, because, yeah, it is boo. And I feel so empty saying to patients, off you go and lose some weight now, because no one knows how to do that, except maybe we've got a little bit of a flash of light there. Because we know, so from many studies, if you are overweight and you lose 10% of your body weight, your stress incontinence and even your overactive bladder will get better by about 70%. I mean, that's massive. And again, I think there are some nuances in this. It's where is your weight? So if you're centrally obese, rather than, it's okay if you've got a big bum or thighs, that's not going to bother you too much, but it's all that central weight. Estrogens are very important in incontinence, actually. We're working this out more and more and more now. And interestingly, for incontinence and prolapse, it's the vaginal estrogens. That's where all the evidence is, rather than the systemic HRT, interestingly enough. I don't know why. But you will, 1 in 4 women will, after the menopause, have urgency. And actually replacing vaginal estrogen makes that feel better. And, you know, I don't know if that's because the collagen becomes better in the vagina, it becomes more supple, there's less friction. So that all feels better. Physiotherapy, mainstay of our treatment. We've now become far more conservative after we all had the mesh scandal, which I'm sure you all know about. So the treatment strategies are do nothing, but obviously a patient wouldn't come to us if they didn't want to do anything. Physio, and again, studies that if you have guided pelvic floor physio, okay, so usually with a trained pelvic floor physiotherapist, actually you've got 70% chance again of making your incontinence better. So what does better mean? It means dry or significantly. This is a patient-reported outcome that is significantly feel better. Ring with a knob. That's not a telephone call from an idiot. That's ring with a knob. So there are lots of different devices now, and they're just essentially, they sort of compress the urethra. So if you want to, you know, go to a wedding, go for a run, go to the gym, you know, this can be something you can use and you won't leak. And there are different things on the market now. There's one called Davine, which is quite nice because it looks like a tampon, and you just put that in and it just sort of pushes up against the urethra. So there's stuff that you can do which does not involve surgery. So surgery is primarily for stress incontinence, and it usually involves lifting up the bladder neck. So we think there's 2 mechanisms of stress incontinence in women. One is the descent of the bladder neck, so when you have a baby, genetics, post-menopausal, that it sort of drops. And so the surgeries are to elevate the bladder neck, and that's usually done by either lifting it up abdominally, so that's called a colposuspension, or by putting some sort of sling underneath the urethra to lift it up. And of course, we're not allowed to use mesh anymore, pretty much. So we don't use that anymore, but we can use a piece of U, so rectus fascial sling, or from the fascia lata, we can take a little piece of that and put it under the urethra. But of course, it's a big doozy having an operation, so if you can do the other things first, that's definitely better. Before I go into prolapse, for overactive bladder, I think I haven't mentioned very much about that, but really the mainstay of treatment is physio, and then we move on to anticholinergics or Betmiga. Their efficacy is, you know, they give a lot of side effects, the anticholinergics, so this is the problem with them. Or you're looking at Botox or PTNS. Now, in NICE, they put Botox before they put percutaneous tibial nerve stimulation. I don't know why, but you'd think, you know, in a sort of for a patient point of view, rather than have injections of Botox in your bladder, you'd think, oh, I'd rather have that stimulation on my ankle, thanks. So that's, you know, literally, I don't know how we worked this out, but apparently if you stimulate the tibial nerve in your ankle, it's linked to your bladder and it calms your bladder down. Who knew? So patients have that for 12 weeks, once a week, and then they have top up. Okay, and they really like it because it's sort of like a nice congenial sort of thing that you do. You get together with other people who are having it. It's a nice chat, and off you go. Okay, so prolapse. So obviously, vaginal walls come down, and there are lots of vaginal walls. So by and large, we either mean the top wall of the vagina, which is supporting the bladder, or the bottom, which is supporting the rectum. And again, or the uterus, which is coming through the middle. So if you imagine like the vagina like a toilet roll, so the uterus is coming through the center, and the walls are sort of collapsing either from above or where the rectum sits. Now, again, independent risk factors are having a baby, giving birth, being centrally obese, chronic cough, which I guess you can't really help, constipation. And this is a big problem, constipation, in the West, because we all sit on upright toilets and we all don't eat properly. So trying to get the patients to think about a squatting type of position when they're pooping is quite important. Trying to mitigate or trying to reduce some of the risk factors. So the patient will come to you and say, oh, I've got a lump in the vagina, often like a ping pong ball, or a sensation that something is coming down. Prolapse doesn't give you pain. Okay, so sometimes I get referred patients with vaginal pain, and that's not typical of a prolapse. You might get this sort of strain on your lower back because you've been standing up all day and this prolapse is dragging down. It might not be too bothersome. So the patient might just say, what's that funny lump? And you say, oh, it's a prolapse. Okay, it's not cancer, is it? No. Okay, see you later. So it depends on what the patient wants and what they're doing. There are some people who will be bothered by, what we consider when we look at it, fairly minor prolapse. And, I've had patients where uterus is literally nearly between their knees. And they've said, well, I just push it up, I do a wee. Is it okay? And as long as you're happy that their kidneys are not being pressed upon, i.e. their distal ureter, then yeah, it's fine. It depends on what they want to do and what they're doing with their life. Okay? May come out, like I said. And if large enough, it can obstruct. So it can actually press on your distal ureters. I've had 2 patients who ignored their prolapse and had renal failure. Ended up in A&E. One of them needed a renal transplant. I mean, have you ever seen an EGFR of 2? I was like, this is a mistake. Who's got an EGFR of 2? Ended up on dialysis, and obviously we had to hitch up her uterus pretty quick, and it was all from distal compression of the ureter. So if you have got someone who says, oh, I'm all right, doc, doesn't matter, I've got this, I know what it is, and all I do is potter around my flat, that's fine. But as long as you make sure they don't have hydronephrosis and their renal function is normal. It can push on the bowel. So if you've got a rectocele, it can sometimes, if you imagine when you're pooing, it needs to sort of almost come out straight. And if you've got a bulge in the vagina, it's making this sort of, trapping or place for trapping of poo. So sometimes women will say, I've got to put my fingers in my vagina to poo, or I've got to push against the perineum to have a poop. And that's because the rectocele is trapping the feces. And so this can be a problem. Now with the bladder, it can cause retention. So you've got to be careful. So sometimes they may leak because they've got retention, if you see what I mean. So it's overfilling and then leaking. So very important to ask about bladder symptoms as well. Sometimes we correct the prolapse and they leak more, okay? Because it's stopping you, it's stopping the revealing of your stress incontinence because it's in the way. It's compressing your urethra. So we straighten it up and then they're not very happy because they're leaking. Okay, and like I said, very rarely causes pain. Now, I've put here the surgery is not just hysterectomy, and that's for prolapse of the uterus. This is really important. Okay, so forever we've said, right, if your uterus is prolapsed, we're going to remove that organ. Okay, poor little uterus. So what happens when you do that is you leave a void in the pelvis, and you literally just have the top of the vagina left, and the bowel can fall on top of that, and then you get a prolapse of the top of the vagina, or a vault prolapse, which is like an inside-out sock. That's how I describe it. It's like an inside-out sock, and it comes out, and it is the worst prolapse for us to deal with. Please don't tell patients just have a hysterectomy. I know you guys wouldn't anyway. But it's the worst prolapse to deal with. It's really difficult to manage surgically as well. So, well, what are you supposed to do then? Well, we can lift up the uterus now. We can, and that's through the abdomen. That's called a hystropexy. Traditionally, it does use mesh. It's the same mesh. It's that same meshy-weshy problem. But it's not in the vagina, so it doesn't cause the same problems. So it's wrapped around the neck of the cervix, and it's actually attached into your sacrum, and it lifts up the uterus, or you can do it with stitches. Or my favourite operation, which is called Manchester repair, which was described in Manchester. And it is essentially amputating the cervix and tightening up the ligaments that support the body of the uterus. So the body of the uterus remains, and you've got rid of the cervix, but it's all sort of pulled up. It's like magic. And I much prefer that if possible. Now, obviously, if the patient's got CIN3 or always having postmenopausal bleeding, well, it doesn't make any sense not to do a hysterectomy. But if possible, I would always preserve the uterus where there is uterine prolapse, if I can. Okay. Sex. I just put that there so I remember. Okay. So this is really, really important because we forget to talk about that, like I just did. Okay, so with incontinence, with prolapse, we forget to ask about sex. People leak when they have sex as part of a complex in stress incontinence. Prolapse can get in the way of you having sex, and we've got to mention that and address that. And particularly where we're thinking about surgery as well. If you do any surgery in the vagina, we're now telling patients, hey, you've got a 10% chance you will have chronic pain just from us making a cut in your vagina, or pain when you have sexual intercourse. So again, very, very important conversations to have, and especially a good reason to try some of the conservative things. Okay, so scar tissue is not nice and spongy like our other tissue. Especially if you're postmenopausal, we're now making a cut in your vagina, your collagen's already depleted, and we're making this scar so that when you have sex, there's not this nice movement of the vagina, it's more rigid. And so you can see how you can get dyspareunia. Okay, and also thinking about sex, look at all these pessaries, these lovely pessaries. So I'm sure you're probably used to just around one. I mean, this is horrifying, isn't it? The donut, it's called. So if you imagine the typical pessary, which looks like a polo, which has got a big hole in the middle, it's just got a rim. That's quite good for cystocele. Nothing is good for rectocele, I'm afraid, except for this cube, okay, which does look like it should be in an 80s car, doesn't it? Like a fluffy dice. Young people won't get it at all. But the ring pessary is good for anterior wall. It supports the lateral walls of the vagina. But if you imagine you've got uterine prolapse, the uterus just pushes through the middle. They're useless. And for the poor rectocele, the reason the rectocele isn't controlled unless it's with this is because when you stand up, okay, everything moves forward. And the rectocele is not compressed by any of these except for this one. And these just sort of, they're staying at the top. So these with the bit filled in the middle, they are really good pessaries for uterine prolapse. Okay, so they stop the uterus from pushing down. So you tend to need something like this. These little holes help suction. Okay, I know they look horrifying, but I promise they're not difficult to insert. They're not too horrible. I always do advise, though, lots of lubricant and encourage the women to use vaginal estrogen because that will keep the vagina then supple and allow this to sit in there. Now, pessaries cause discharge. Okay, so you've got to warn the patient about that. Now, for some women, that's okay. Okay, they're happy to put up with that, and their prolapse is controlled, their symptoms are controlled. But it does cause quite a lot of discharge, and that can get really annoying. And estrogen is a good way of preventing that, okay? And look, all these other little funny shapes, and they're good at lateral wall support and sitting at the front of the vagina. I have to say, I've never used a donut. I mean, it's just a heavy, I don't know who invented that. A man. Okay. Sex. So, sex, important, because you can't have sex with any of these in. Okay, you can only have sex with a polo in. So for some of these, this one, we train the patient to take it in and out. This one, the patient, because it folds, they can take it in and out, and some of these, okay? So actually, women are really, we're quite patronising, aren't we? You'll never possibly can't take that out yourself, but they can. And they're very good. And there's this generation of women who are used to using, cups and diaphragms, so they're well up for putting something in and out of the vagina, and you just watch them put it in and out. Best way to do it is to stand up, put your foot on the toilet or a chair or the side of the bed or whatever, so that you're closer to yourself, and then you can put it in and out. Okay? And lots of other things going on. So your patients are going to ask you about this, okay? They're going to ask you about this chair that vibrates, and then it makes your prolapse go away, apparently. Okay? It does not, okay? Don't use it, people, okay? And then you've got these cushions. These are quite good, okay? Obviously, this is a symptomatic relief, isn't it? So you're going to go out somewhere. It just sort of, you put it in your knickers and it just pushes up against the prolapse, okay? Why can't prolapse knickers be sexy? Why? Has to be look like this, doesn't it? I mean, it looks like some sort of torture contraption. But they're just support pants, and some of our older ladies do like them. They can wear that, they can just go out. They're not bothered with trying to fit a pessary. They're not bothered with surgery, and they can use some of these supportive things, and they're happy. Yeah. So worth a go in some patients. Okay. If you showed, I don't know, one of a younger patient, they'd be horrified, wouldn't they? Okay. So estrogen, I've got to mention it again. Okay. This is how a certain age of woman, including me, feels like, okay? This is what we'd like. So estrogen, very important for incontinence, prolapse, and UTI. So I'm going to mention it again and again. And the evidence is with vaginal estrogen. And vaginal estrogen is so safe. That's the other thing to mention. It's such a low dose. It's very poorly absorbed into the rest of your body. And mostly even with breast cancer, people are happy to use it, or anything else, okay? Physio. Yes, yes, yes. Must have physio, okay? So we try not to operate on people who have not gone through a physiotherapist. If nothing else, it doesn't work. They can just train their pelvic floor. You have a better outcome after you've had some surgery if you go and talk to your physio. There's lots of devices that help you with your pelvic floor physio, because actually it's quite difficult when you say, contract your pelvic floor. Like, how am I supposed to do that? So what these devices do is they sit in the vagina, and you can squeeze on them, and your little app, we've all got phones now, little app will tell you you've been doing it well or you haven't been doing it well, okay? So these are very good, and this is, I think this is probably the leader, the LV pelvic trainer, okay? And I've put we should learn this at school, and we should. Yeah, we are not telling people what they're up against, and maybe if we did, we wouldn't have half of these problems. Okay, poop. So I'm going to mention it briefly. Obviously, you know the red flags, okay? Blood in poop, bad news. Constipation, always ask when anyone comes with a prolapse or even incontinence about constipation. We're all constipated, so we all need to use the lovely squatty potty, okay? And that's how we should be sitting. So you put this little stool, we don't have to buy this one, although it fits nicely under here, but it essentially puts you into a squatting position so that your pelvic floor muscles can relax and your sphincters open naturally, rather than you push on your sphincters, okay? So hemorrhoids are a problem of the first world. They are not a problem of the third world, because we sit on upright toilets. And then we get pelvic floor problems as well. So your pelvic floor almost has something we call dyssynergia. It doesn't contract properly, it doesn't relax properly, and this is causing a lot of problems. Okay, so squatty potty is always worth a mention. And this is what it's supposed to do when you are squatting. You are able to relax your puborectalis, okay, and your rectum becomes straight. You can poop properly, okay. This, your patients are going to come to you and ask you about this, okay, vaginal laser. It's supposed to be the, rejuvenate your vagina, okay. Now, be very careful, because I have seen patients who've been scarred and burnt, okay? So again, it's about reputable people. There isn't a lot of evidence in stress incontinence. There is some evidence in terms of the rejuvenation part. So it does stimulate the collagen, but hey, why don't you just use some vaginal estrogen? It'll probably do the same thing. So there isn't any evidence for stress incontinence, and people do ask me about this a lot, okay? So I wouldn't do it personally. Okay, UTI. So we've set up a chronic recurrent UTI clinic at the Portland, and I run this very same clinic at the Whittington. It's the only one in the country, actually. It's a tertiary referral centre for UTI, chronic UTI. And this is a huge problem, okay? And like I said, every doctor will see people with UTI. And recurrent UTI, so if we imagine about 50% of women, we reckon, but I think it's more, will have one UTI in their lifetime, and 30% of those will have recurrence. That's about 4 million women in the UK, okay? And this is a mounting problem. At the Whittington, we've got 1,000 patients on our books, okay? So there's a lot of patients, a lot to deal with. And the problem is that we've always concentrated on this, okay? So we've always said, oh, it's the E. coli, let's kill the E. coli, and then we'll all be happy and everything will be good. But we've got E. coli all over us. We've got E. coli in our bowel, you know, we've got streptococcus over us, staphylococcus. You know, you don't want me to spit on a Petri dish, it will be disgusting. Okay, so there's lots of other things going on. And it's an interaction. It's how do we interact, the host, we've forgotten about the host, and we've forgotten about the host in a lot of disease. Okay, so we trust our test, don't we? Let's do the dipstick, let's do the urine culture, let's do the MRI. Actually, let's just talk to the patient. They know what's wrong with them. So the host has some issues as well. So if I've said to you that 30% of women will have recurrence, well, what about those? What's with the 70%? Why don't they get a recurrence? Why do you have some women that say, oh, I just drink an extra glass of water and then my UTI goes away? You know, there's annoying women. And then some women are blighted by this. And it is horrible. So anyone's had a UTI, that horrible frequency, urgency, pain. But then imagine that every single day of your life. I mean, I have patients who are suicidal, and you can understand why. This is some data from NHS Digital, actually. And we basically looked at outpatient attendance for chronic cystitis, interstitial cystitis, which actually is probably just a chronic UTI. And you can see year on year on year, it's going up, up, up. And I don't know why. We've got our theories. And one of those theories is that we give women 3 days of antibiotics if they have a UTI. Yeah? If you're a man and you've got prostatitis, you'll get 14 days. You might even get a month. If you've got acne, you can have UTI. You can have antibiotics for the rest of your life if you want. Broad spectrum ones. But it's women with UTI who are responsible for AMR somehow. I don't know how. Okay? And here's inpatient admission episodes. Again, up, 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 year on year on year. Okay, so big problem for the NHS, and actually it's costing the NHS millions of pounds. Okay? So we asked 2 GP practices, can you tell us from your excellent IT system, which somehow the hospitals don't have, how many people come back 3 times or more with a UTI? Okay, the same person coming back in the year 3 times or more. And look, up and up and up and up we go, okay? And I think it's this 3-day prescribing. What happens with 3-day prescribing, of course, is you yo-yo. You just have shorter courses, but loads of them. So when I see patients, and I see patients at about year 6 of having UTIs, when they want to kill themselves, horrible. And when you look through the history, you just think you might as well have just had a continuous antibiotic. Why this stop, start business? Okay? So why is this a problem? I've explained to you a little bit about maybe to do with the prescribing, but actually one of the biggest problems is how we diagnose UTI. Okay, so we love to categorize, don't we? And we love to put people in boxes, and we say, well, if you've got chronic symptoms, i.e. they've gone on for 6 weeks or 6 months, then you, and they are in this particular descriptive, like this, then you're going to have one of these, okay? But look how they overlap in all their symptoms, yeah? Except for pain doesn't occur in overactive bladder, but it occurs in everything else. And biology is a continuum. You know, how can we say, right, you've definitely got IC, you've got maybe a UTI? One of the things we can do is to exclude infection, yeah? I don't have to tell you about the impact. I'm going to skip over this, but it's a big problem for the NHS. And in fact, the last document I read by the NHS was this document called Incontinence Care, and it said we must reduce urosepsis by 2000. You know, by the year 2000, we must reduce sepsis. No, 2010, by half. Okay, obviously we haven't done that. Okay, so in an ideal world, I'm going on to diagnostics because this is really important. You're all going to hate me though, because I've got an answer for you. Okay, and that is that someone comes with symptoms, you do a dipstick, and if the dipstick's positive, you might send off for a culture. Yeah, and hey presto, you've got UTI, you haven't got UTI. Okay, wrong. Sadly wrong. I wish it was the case. So the MSU, if we start with the MSU, you know it's 75 years old. Okay, we still do it the same way. And it was described by someone called Cass, and he looked at pregnant women with pyelonephritis, and he said, if you've got pyelonephritis and you're pregnant, to diagnose a UTI, you should have 10 to the 5 colony-forming units per mil of a known uropathogen, okay? What we knew then to be a uropathogen. Well, what is a uropathogen? Don't know. Then you've got UTI. But of course, we have applied that same threshold to non-pregnant women, men, women, children, every type of person. Doesn't matter what age they are, doesn't matter what they look like. If you have 10 to the 4 colony-forming units per mil, you don't have a UTI. Okay, you could have the symptoms of a UTI, but you ain't got a UTI. So it's very important that we understand this shortcoming, and I think that is the first start. And not to say to a patient, well, your MSU is negative, okay, so you're mad. I know none of you say this to patients, but you know, it's really important that we do trust the symptoms. The biggest predictor of a disease are your symptoms. Yeah, that's how we've been trained. That's coming back from Osler and whoever, that it's your symptoms and signs that predict disease, and the tests add to that or detract from that. So we've got to go back to that, talk to the patient. The way that the MSU is done, you know, who knows when that urine gets to the lab? Seriously, you know, from GP practice, it can be 5 days. You know, imagine a bank holiday, you've had it. And if you talk to the Whittington lab, they will tell you Tuesday's Enterococcus Day. I said, what? What do you mean Tuesday's Enterococcus Day? And Neil said to me, he was our lead BMS there, he said, well, what happens is the urines at the weekend, they just get sort of, I don't know, left somewhere. And then they come up to the lab, we stick them in the fridge, there's no one around. We plate them on a Monday, and then we read them on a Tuesday. The only thing that has survived over the weekend is Enterococcus, okay? So how is this diagnostic? It's awful. We go on about mixed growth, okay, that doesn't mean anything. Well, we now know that actually probably most disease is probably caused by a mixture of microbes rather than one evil one. And the thresholds I've mentioned. But of course, we choose culture medium, which is biased. We first select that medium which will grow E. coli, okay? So I read, when I was doing my PhD, which was on this subject, I read a paper in the Lancet, and it was a discussion. They used to have these debates then, which was really fun in the 80s. And they'd moved urine culture from being a very sort of broad thing where they did anaerobic culture, they did all sorts of things, and they moved it to, no, we're just going to do it in air on this particular culture medium which will pick up E. coli. And everybody was horrified. They say, well, what about other things? What about anaerobes? What about streptococcus? It grows better in CO2. But this is what we're doing. Okay, so I would say to you, think about that, okay? Not that I have the solution. Dipstick, pretty useless. It is good for picking up blood, and it is good for picking up protein. I will always do it, okay? So you've got blood and protein, you've got kidney problem. So do always do the dipstick. But of course, this is what we don't understand. So you may say to me, what is chronic UTI then? It's rather than just symptoms. How do we get it? And I think we now understand more and more about bacteria and what they do. So we used to think they just float about in your wee, yeah? But of course, that's silly now when you think about it, because you just wee them all out. but actually they can invade the urothelium, and they can reside in your urothelium, and they can switch off. They can stop dividing, so antibiotics can't get them. Antibiotics don't penetrate the urothelium very well. They collect in your urine. So you're just having this battle of bacteria that live there. They'll divide, they'll come out, and we think this is propagating chronic symptoms. Okay? Thank God, NICE have now recognized that, hey, yes, there is a problem with diagnostics. So at least this conversation has now been had. So they set up a diagnostic advisory committee, and they've acknowledged some of these things, thank God. Okay, so watch this space, and hopefully we can get you some good diagnostics, which is what my research group also works on, actually, is an AI which can do microscopy of the urine and help us. I can talk to you about that later. Okay, how are we going to treat these patients? So I think it's really important. By the time you're getting to recurrent, everyone wants to do a wee. That's what I tell myself when people leave. So it's really important. People have chronic problems. They will have pain. They will have frequency urges. They'll be getting up at night. They can't sleep, okay? So the strategy has to be not only treating the UTI, but it has to involve pain management, really important, okay? So whatever antibiotic I'm giving you, if you can't sleep at night, well, life is shit, isn't it? And prevention is important. So I always think of the vagina as the gatekeeper, okay? So it's preventing you from having infections ascending into your urethra and into the genital tract. How is it doing that? Lots of things which we're losing menopausally. Things like the labia majora, nice and plump, labia minora, second barrier. You have estrogen, which helps you produce a discharge. That's a natural barrier to bacteria. Estrogen makes your pH low. Okay, so it gives you acidic pH, and hence promotes lactobacillus. So all of these things are helping us. So prevention-wise, if we can bolster up the vagina and the vaginal microbiome and the conditions in the vagina, how do we do that? Okay, so here are the vaginal commandments, okay? Limit chemicals. You would be surprised, I'm sure. You know, all this femme fresh and all of this sort of stuff. No, no, no. Okay, any moisturizer for the vagina or lubricant with glycerol or glycerine, don't use it, causes thrush. Okay, and don't put soap there ever. Just use plain water, don't douche. Okay, so these sorts of things. Keep the pH low. How do you keep the pH low? Easy for me to say. Estrogen, but I've started to actually give people boric acid pessaries, which are actually really difficult to come by. We are trying to source them at the Whittington. So patients are often buying them. So you need to build up a sort of network of who are the reputable people. But all it does, the boric acid, is drop the vaginal pH. It is a treatment for BV. It's a treatment for thrush. And I think it bolsters up these patients who are having chronic UTIs. And consider estrogen or a moisturizer, okay, in the vagina. That will symptomatically help you as well, but we know all the good effects of estrogen. And I've put pelvic floor exercises, and that's both to strengthen the pelvic floor, but also to relax it. Once you become a pain patient, so if you imagine your pelvic floor's had this bladder sitting on it, which is inflamed and enraged for months and months, if not years, by the time they get to me, and that triggers their pelvic floor to be extremely tense and tight, and that's where a lot of the voiding problems are coming from. Okay. Estrogen, of course. Yeah. Now, what I see is the average age of my patient is 56, okay? So this is happening at the menopause, and I think it's for some of these reasons that we've said. It's this lack of estrogen probably. It's the atrophy. It's all the good things that estrogen does in promoting the other good bacteria, although I'm not allowed to say good bacteria. But if you've got a certain population in the vagina, they're going to push the other ones out of the way. And I think this is the best strategy, to not think about an isolated, we must kill E. coli, therefore let's give you amoxiclav. No, it's actually to restore the microbiome. How do we restore it? Okay, how do we not nuke everything? How do we get the good ones back? And this is the conversation we're going to have more and more, okay? And there you are, estrogens again and again. They make your pH low. And if we look at, there are some studies where they've replaced estrogen in patients with UTI, and that has had a beneficial effect and promoted L. crispatus to come back, okay? I'm going to quickly buzz through things please don't do because there's not enough evidence, okay? You will see lots of patients, short courses we've spoken about, okay? Sadly, we are hamstrung. You have to give short courses. You haven't got a choice. You will be thrashed by whoever thrashes you because you'll be an outlier. But just remember that probably a third of women are going to fail this. If you can squeeze in some extra days, probably try to. This is really popular. Okay, please don't do it. So I think this comes from ITU, where people with pneumonia who were dying were given rotating antibiotics. So I do see patients who have 1 week of nitro, 1 week of trimethoprim, 1 week of amoxicillin. This is going to cause resistance. Yeah, it's a popular thing. It seems like in Urogynaecology. You guys are far too wise for that. So don't do that. There's no evidence in UTI. Bladder installations, okay? So bladder installations, there are two types. One is an antibiotic like gentamicin, which sadly only just swirls around in the wee. It doesn't penetrate the urothelium. So it might work, it'll make you feel better for a bit because it just picks up all the ones that are floating around. And then we've got this gag layer replacement, okay? So we've got, that's the aminoglycan layer, which is on every mucosal surface, okay? So it's in your mouth, up your nose, wherever. And the hypothesis is that if we replace this layer, which is broken because of chronic inflammation in the bladder, that this will help you. Sadly, we don't know if it sticks in the bladder, okay? But it's very widely and commonly used, okay? But there's no evidence of efficacy, unfortunately. But watch this space. There's an NIHR study about to happen on it, okay? D-Manose. Okay, D-Manose supposed to stop E. coli sticking in your bladder, but unfortunately the research is not brilliant. We need to do more studies on it. They're all sort of, different types of doses, patient self-reporting. So again, literature's not great. It's quite sugary as well, costs money. Right, this is what we do at the Whittington and this clinic that we've started at the Portland, okay? Now, again, we've only got retrospective data, and if anyone's got £2.2 million, please give it to me. I can do a randomized control trial, okay? So constantly applying for grants to do a randomized trial of this, but essentially we see patients who are on, last chance saloon. They're 5 years down the line where they are just feeling terrible. And we are giving them a full dose of narrow-spectrum antibiotics, okay? And this is based on our research and our studies. They're very carefully monitored, though. So we do fresh urine microscopy in the clinic. Now, why do we do that? It tells you that there are white cells in the urine, and we've been able to see the patterns of how white cells go up and down if you treat patients and how they actually correlate to symptoms. And this is very important. Now, white cells implode. So within 2 hours, you lose that white cell signal. That was the highlight of my PhD, leaving we on a bench and seeing what happens to the white cells after 30 minutes, 1 hour, 1.5 hours, and they implode. So you can imagine getting a wee to a lab. The first thing they'll do is they'll microscope it and they'll say, screen negative, chuck, okay, because there's no white cells in it. But they've just imploded by that time. So if you do it fresh, you are identifying what is the host doing, okay? We all have bacteria in our bladder. I've got E. coli, enterococcus, all sorts of things, because again, when you do research, the first thing you do is look at your own wee. So we've all got bacteria, but it's what is the host doing? What am I doing to tell the doctors that this is upsetting me? And one of the things you're doing is producing white cells. In postmenopausal women, it's actually quite rare to find white cells in the urine. Premenopausal women, less than 10, okay? So, and that's fresh microscopy. But of course, this is not for the faint-hearted. This requires a lot of governance, a lot of monitoring of patients, 3 monthly bloods, LFTs, U's and E's. If you put anyone on prophylaxis, okay, once nightly dose, please can you do their LFTs, especially if you put them on nitro, okay? So there was a case in the MD UK files where someone was given nitro as just a once nightly dose, and it just messed up their liver function, okay? So we are treating these patients. We've got an 80% success rate, okay? But they are on antibiotics for a year. And we also use methenamine hippurate, which is the new kid on the block, but it says old as old can be. It's an antiseptic for the urine, okay? Interestingly enough, we don't know how it works. It's medicine for you. But we are actually doing some studies in vitro of how it works. What we think is happening is it goes into your bladder, you take it orally, it's excreted exclusively in the urine, and it suppresses overgrowers, okay, whatever that means. So the diversity in the bladder of people who take methenamine is more than people who do not take methenamine. So we think it's allowing the other populations to come back. Okay? Everyone asked me at AMR, okay, so you're giving all these patients these antibiotics. Now, by the time they come to see us, actually, 30%, I don't know how this happens, you guys can tell me, 30% of the patients we see at the Whittington have already got a resistant bug in their urine to cefalexin. How is this possible? And there's a background thing going on, or they're having these yo-yo antibiotics. Interestingly enough, even though we've got 1,000 patients on antibiotics for over a year, some of them, we are not an outlier for AMR. And I think it's because we poorly understand AMR. It's not a direct relationship where, you know, you take antibiotics, you become resistant, or you stop them and everything gets better. So if we look at all our data, we're the least prescribers of cephalosporins in Europe. We've reduced our prescribing. And in fact, GPs are excellent. They've hit all their targets for prescribing. But our AMR to cephalosporins has not gone down. Okay, why? Don't know. So methenamine, I mentioned, this is the new kid on the block. You can prescribe it. It's in NICE. Yeah. And please consider this. So this helps me to get people off antibiotics or to not start them on antibiotics if I can help it. And it's the antiseptic. Okay, it's cheaper. Well, once the company knows that we're all going to prescribe it, it won't be cheaper anymore. Okay, vaccines, they're still experimental. Okay, that's sadly. But there are some good ones. Euroimmune is mostly about E. coli. I couldn't understand it at first because I thought, hang on a second, we've all got E. coli in our bladder all over the place. Why do we need to ingest it for us to be immune to it? But it is a thing, and it's to do with the innate immune system and producing the antibody trigger. Okay, but so this is a space definitely to watch because there's some good stuff coming out from the States. Everyone asks me about this, all the patients. Can I have this new antibiotic? But unfortunately, it's still clinical trials. Okay, but your patients are going to ask you about this. I imagine it will be very restricted in its use. And let's not forget pain management. This is really important. Please don't forget this. Please give your patients pain management. I use a lot of Nefapam now, and it's a PRN. It's centrally acting non-opioid, and it's for moderate pain, and it's pretty good for those awful acute flares where patients are feeling really, really terrible. Bicarbonate of soda, just for that when you're desperate and it's awful and your bladder's burning, it just alkalinizes the urine, it calms it down. Just a teaspoon in a glass of water, yucky moo. I mean, Tapida is a topical spray. It contains tea tree oil, and that's soothing for people who have urethral pain. If I had a cure for urethral pain, I would be very happy. Okay, so of course I've got to plug my research. So our research at UCL, and we're looking at chronic recurrent UTI. We've got a 10-year research program looking at pathophysiology, new treatment strategies, non-antibiotics. So I'm very excited about not ever prescribing an antibiotic ever again. That will be lovely. And about diagnostics, very, very importantly. Okay, so I guess UTI-wise, these are some of the things to think about. Your treatment's going to fail in about a third of patients. okay? And just the tests. Just remember that they're not all there, you know, that we think they are. So trust the patient, give them the estrogen, and be kind to them. Okay, thank you.